Don't lick the tip.
Oh
That's
my God.
not a good idea.
That's not what I taught y'all.
Now you gotta keep it.
You do use actual lubricant on that, but we'll get to that in a minute. Okay, use layman's terms. What's that mean? Don't be saying barium, don't be saying upper GI, don't be saying fundus, all these words that we learn because they're not going to know what you're talking about. They'll think you're saying something's wrong with them. So, we're going to drink this solution. What is it? It's a special liquid that lights up your organs. We're not going to say it's barium contrast. That actually kind of sounds scary when you say it that way. But it's a liquid that's going to light up your organs and allow us to see them better. Layman's terms. It's going to be very thick, chalky. It's going to taste kind of bitter. But we need you to drink big gulps so that we can see your organs. We need you to. Remember, secret words, I need you to. Not will you drink this? Because what are they going to say? No. Heck no, I'm not going to drink that. Inform them that the room will be darkened. Believe it or not, it does startle some people still. Adults, yes. It's all right, Jay. I won't tell your secret.
I know.
I get scared of the dark too.
It's night lights are important.
My kids still see the nightlight. I can't say anything. You do too? No judge. Introduce the patient and the fluoroscopist to each other. When the doctor comes in, make sure they know that's the doctor coming in. Don't just let them start working on the patient without knowing who's actually doing the procedure. That's going to help comfort them as well. Plus, you want them to know who the doctor is in case they screw it all up and they know it's the doctor doing it, not you. I'm just saying. And if they start asking those weird questions like where's the buttons at, they know it's the doctor asking that. You follow me?
Yeah.
That makes it worse.
The resident.
The resident?
Yeah.
Which one's the save button? Why do they say it from a patient? I'll never know. Exposure time. We're going to keep the exposure times extraordinarily slow. Why? Because of constant digestion via peristalsis. That's going to be what we call involuntary motion. We cannot voluntarily cause our stomach to contract, correct? Unless we gag ourselves, of course, but that's still considered an involuntary response. Because of that involuntary peristalsis, we need to eliminate the motion, which is a major artifact on fluoro and x-rays. You okay? Yeah. Thus, we're going to use short exposure times. Peristalsis is going to be great slide, by the way, big star on this. Peristalsis is greatest in the stomach and the duodenum. It slows in the distal part of the GI tract. Therefore, where would you need the shortest exposure times?
In the
stomach and duodenum primarily. You could make the exposure longer.
You're good.
I'm making my screen blank.
Sorry.
You can make the exposure longer when you get closer to that distal portion, small intestines, large intestine, so on and so forth. Now, peristalsis is affected by body habitus, of course, pathology, any kind of narcotic pain medicine, body position, and respiration, which is why we try to get them to suspend their breathing to eliminate the peristalsis as much as possible. Okay, so close collimation, optimum technique factors. That still applies at fluoro, even though I'm sure you're seeing them just open it up. I get so tired of hearing that term, open it up. Everyone keeps telling me, just tell me to open it up. Close it down. We're going to say it reverse. Let's close it down. Let's close it down.
You ain't in it. It's like a bubble.
You-
It's weird. So it's like you're not. It's just, no, get in there. Get in there.
Use gonadal shielding accordingly as well, even during fluoros, unless they are having like a lower GI exam. Don't put your shields there. It's going to get all nasty. I know, but you still technically should. I was waiting for someone to say that. You've probably never seen them shield on a fluoro. Technically, they should still shield on fluoro. Well, think about it. That's a lot more exposure. You're getting constant exposure via a video type x-ray. So why wouldn't we shield? Because we're lazy.
They don't care.
Because they don't care and they're lazy. Exactly. But once again, imagine it's you on that table. You want to have a family one day. Don't be zapping my stuff. I want to procreate still one day. I don't want that cancer.
Not now.
Oh. What? Oh. Wow.
Y'all are feisty today. Okay, so a few review questions. Peristalsis is affected by which of the following? We just went over this.
Use of
What affects
narcotics.
peristalsis?
Oh,
It's 1 and 2.
We just saw the slide.
Yeah, 1 and 2.
It's 1 and 2.
3, all of
I
them.
think.
Thank
Yeah.
you. It's all three. Yes,
What?
it's
What
all
bo-
three.
What body position hindered it? I don't remember.
If you are in a PA position, it's going to affect peristalsis differently.
Oh, because it's on the. Yeah, okay, it's fighting gravity.
Iodinated contrast agents move through the stomach slower than barium contrast? True or false? That's a great question.
Slower. I mean.
No, I
Well,
don't
yeah.
think so. That is the thinner, so it moves
Usually
faster.
says false.
You're correct.
It says
Shaheen
slower.
was correct. It actually moves faster because it's a thinner consistency, whereas barium's a lot thicker. It moves slower. That's why it's an advantageous contrast if we can use it with the barium. We want it to move slower. We get a better visualization of all that inner intestinal tract, stomach, so on and so forth.
So what was it, false? She said?
It was false. All right, let's go through the actual projections. We're going to start with the esophagus. Not too many to know on this one. We have a simple AP or PA. We have the AP-PA oblique, and we have the lateral esophagus. Now, these are not the films the radiologists are taking, by the way, as we go through these positions. These are the films you would take as a tech if they asked you to do plain films alongside or after the fluoro is finished, which is what they used to do on most fluoros. You don't see that very much anymore. Where I first worked, they would still do this all the time. Some facilities do still like the plain films. Until they completely dissolve them, we'll have to keep learning them, unfortunately. So once again, keep in mind these are plain X-ray films, not the fluoro freeze frames that they typically do. So we would be asked to do an AP or PA, AP or PA oblique, and a lateral. And the obliques are going to be a specific oblique that we're going to get to in just a second here. All right, so AP, PA esophagus. Patient prep for an esophagram, by the way, is not required. Does anybody know why?
Because they're not looking at the bowels.
Exactly. We're not looking at the stomach, we're not looking at the bowels. If they have stuff in there, it's not going to affect that exam. We're only looking at the esophagus. That's it. We have the option of single or double contrasts. Single, barium or water-soluble ionated contrast. Double is going to be the barium with the carbon dioxide crystals. Usually the double contrast will be done if they suspect some kind of pathology in the esophagus, if they want a better look of the internal portions of the esophagus. First part of the exam is fluoroscopy of the swallowing, followed by these plain films. And let me let you use your critical thinking. How do you think you would obtain these as a tech? If you're doing a plain, let's say you're doing an AP esophagram, and you gotta get an X-ray catching that barium going down the throat or the esophagus, how would you do it? What would be the process of doing that? Did you probably never seen that before? Because the fluoroscopist usually does this.
Yeah, I was gonna say they stand up.
But think about it, what would you do? We got to capture barium in the esophagus. How do I do
You
it?
take the picture as it going
Yeah.
down with the
We have the patient in an AP or PA, straw in the mouth with the cup. I told them to start taking big, slow gulps. I'm going to watch as they swallow, kind of like when we're watching people breathe. As they swallow, snap your picture, and that will get the full barium-filled esophagus. Can be harder than it sounds sometimes, though. You got to catch it right at the right moment. Okay, so position, supine or prone, without rotation.
You know,
you
if
can't
you
breathe.
wouldn't say it, it won't seem so obvious that you pronounced it wrong. If you won't correct yourself so
Oh.
distinctly, it won't seem so
Well,
obvious.
it bothers me, so I gotta correct myself. Part position, head turned to the side. This is a gold star question right here. On esophagram's, you must have the head turned to the side to facilitate drinking. You never want to put the straw in their mouth with their head straight back. Why? They're probably gonna choke if they do that. You want the head to the side, straw in the mouth, and then tell them to take those big, deep gulps as we take that X-ray. Central ray. Write this down. I would recommend, guys, because all this centering is going to be hard to keep track of. You try to make yourself a little chart for this test. The central ray locations for all these exams are vastly different. And this is an example of one. T5, T6, not one we use very often. T5, T6 is for an esophagram. What the registry will do to be really mean, they'll put T7 on there. Why? They know you're used to using that. For what? Chest X-rays. But for esophagams, it's going to be a little bit higher. We're star of your show, T5, T6. 14 by 17 cassette, collimated to a 12 by 17. So like I said, you're going to see these central rays vary quite a bit, especially when we get to the stomach. But I would start making myself a little chart, because that's probably the questions people miss the most on this test, is the central ray locations. They're tough to remember, I'm not going to lie.
So they can't be operated.
They can be. It can be. It depends on what the rate. Well, no, you know what? I take that back. I'm sorry, Monsi. For the fluoro part, yes. For the plain films, no. We want to lay them down. All right, so what are we looking at? Esophagus from the lower part of the neck down to the stomach. We, of course, want the esophagus with barium. We get that by telling them to take the big, deep gulps, and we take the exposure as they're swallowing. For evaluation criteria, we're going to see esophagus through the superimposed T vertebrae. Very important. That tells us that the patient is not rotated. We do want that esophagus right in the center of the film, in the middle of that T spine, T vertebrae. No rotation. We will see a little bit of the stomach, as it already said. We do want to see down to the stomach at least. Yeah, I'm thankful we don't have to do these anymore, the plain films. It's very time consuming, especially with upper GIs. They still make y'all do plain films for small bowels though, right? They'll do the KUBs, like 15 minute, 30 minute, all that?
Yeah.
Okay.
What does it mean when we, like yesterday they came into EC and we were like, we need a CV, we need a CV.
Who was asking for that?
But Miss Bum was like, oh, we can do that.
They can put films on a CD.
Yeah. See your pictures.
Like all the stuff on packs, you can transfer it to a CD.
Who do this?
That's just because they're going to like an outside.
Prior patient.
Likely transfer, yeah. Okay, so here's the obliques. So PA, AP, oblique, esophagus. We only do two specific obliques, guys. Write this down. They're a very missed question. We only do REO or LPO. That's because of the way the esophagus is going to be moved away from the spine and projected on the chest cavity. That is going to be recumbent, by the way. We're still not standing. Another missed question, guys. This is where they get really sneaky and kind of cruel. 35 to 40 degree oblique, not 45. It's a 35 to 40 degree oblique of REO or LPO. By the way, does anybody know why we do those specific obliques?
Isn't it to free it away from the vertebra?
It's to get the vertebrae out of the way, but why would we do like an LPO and not an RPO?
Heart shadow.
Sternum.
Heart shadow.
Heart shadow.
So we want it projected against the heart shadow. So LPO, it'll be right on top of the heart. RAO, same thing. Be on top of the heart.
You said what shadow? The
Heart
what?
shadow.
Heart
Oh.
shadow.
Out the way?
Huh? We want it on the heart
Oh,
shadow.
You want the vertebrae on the heart shadow?
What you want?
Oh, the esophagus. The esophagus.
esophagus on the
We
heart
want the
shadow.
esophagus away from the vertebrae on the heart shadow.
It's like a stern.
And to find
Like the sternum, very similar. Correct.
That's it's like the sternum.
Did you say I didn't hear you? I'm sorry.
But it's okay. Players will say it.
Central ray is the same as the APPA. T5, T6. I don't care what y'all say. Y'all are fun in the afternoon. Y'all are hilarious.
We didn't ate.
how do you
I've
find
been missing out.
P5 and P6?
How do you find it? You have to kind of just learn how to eyeball it, unfortunately.
Or can you do
Or you
P7?
can find T7 and just go like 1
Yeah,
inch
just
up.
go up like T7 for the chest.
What else is at the border of T7?
So we're centering on the elevated
Isn't
side.
it the
Correct.
inferior
That's
scapula?
T7.
Well, thank you for bringing that up. You do sit on the elevated side.
1 inch of
Yes. That guy looks really angry in that picture. He doesn't have a cup in his mouth either. You would need to see the cup with the straw in his mouth.
Because then you have that white stuff on. Should I have said barium? I'm sorry.
So there we go, guys. Esophagus from the lower part of the neck to the stomach. Esophagus between the vertebrae and the heart. And I put in red for you exactly the points I want you all to know because we're going to be going through a lot of evaluation criteria. I would say for this chapter, focus on the points for the positioning, what I have in red.
Bless you.
The stuff I have in red is the main points I want you to know. So esophagus from lower part of the neck to the stomach, esophagus between the vertebrae and the heart. As you can see, it is projected on the heart shadow. That's what we want. And that would be an example of two single contrast studies. Single contrast. I can't wait till we get to the deficograms. Y'all behave yourselves now.
Wonderful.
I did have more in my mouth than I can fit it out.
Lateral esophagus. Moving on. We'll go a little bit faster since y'all have these notes. We gotta catch up a little bit. So patients should be facing you, by the way. Why do you think that's important? We put them in the lateral so they're facing us. Why would that be important?
In case
So
they
they see
choke.
Actually, see what's going on.
Not only that, but we want to be able to see them swallow.
Right.
We got to take the x-ray as they're swallowing. So if their back's to us, we're not going to be able to tell if they're swallowing the barium. So we have the choice of right or left. Just make sure they're facing you. Arms forward, on forearm on the pillow, MCT centered. We're still entering at T5, T6. So all your esophagograms, you center at T5, T6. It's easy to remember. Don't select T7. That will be an answer choice on your test. I'm just warning you. Perpendicular central ray on all these projections, by the way. All perpendicular, no angulations. Already, I just started. Trying to break already. I think my violin's on its way from eBay. So it should be here next week.
The smallest violin.
Take some lessons.
All right, so what do we want to see on the lateral? Once again, focus on the red points. Proximal esophagus without superposition of the patient's arms. They need to be up and out of the way. Esophagus from the lower part of the neck to the entrance of the stomach. We're just in a lateral view. Lateral view. So this projection right here, this x-ray, would you say that's pretty suboptimal? Which one of those evaluation criteria did they not do?
Raise the arms.
They didn't get the arms out of the way. See those arms all up in the way? They're completely relaxed.
I have a question.
What about
Yeah,
Is the SID 72 or 40?
40.
40?
40 for all these. Yes.
what about collimation?
Collimation on these, I mean, you can collimate down basically to the spine and be safe.
Okay.
Where's the neck? It's superimposed by the shoulders. You also need to do a swimmer's on that. Like a swimmer's esophagus. I don't think it's a real projection, but it might help. Okay, is that how y'all feeling right now?
Yeah.
All right, let's talk about the GI series. Okay, so they can be called two names, gastrointestinal GI or upper gastrointestinal, which most of us know it as the upper GI, UGI. It goes by both names. We use it to not only evaluate the stomach, but also distal esophagus and some or all of the small intestine. Keep that in mind. It's not only stomach. It may include, and it should include, scalp x-rays, scalp KUB. Why? Because they do have to prep for this exam. We do the scalp image to check for the prep, to make sure that they're nice and cleaned out. Usually if they see they have not been cleaned out, at least in my experience, they'll often reschedule that procedure. The only age group they do not do that, at least where I worked, is in kids. Kids don't need prep. At least where I worked, they didn't need prep.
Is that because they're fairly regular?
Honestly, I don't know why. I don't think I ever saw the reason. I don't think I ever even asked the reason behind that. I just know they didn't care about prep with kids.
Okay.
Not sure. Okay, so what's the prep for an upper GI? We must have the stomach be completely empty. It's also desirable to have the colon free of gas and fecal material. Why? It could obstruct some of what we're trying to see. So, non-gas forming laxative may be administered 1 day before the examination. Food and water, bold red there, guys. That's a good registry question. Food and water for an upper GI is to be withheld 8 to 9 hours before the examination. So you essentially have to fast before the exam, but not for too long. Not as bad as for a large intestine study. If the small intestine is examined as well, food will be withheld following the evening meal, so a little bit longer. Also, fun fact, nicotine and gum are thought to actually stimulate gastric secretion, so these are often restricted to the same time frame. So you can't even chew gum. Big no-no.
NPO for 8 hours.
And cigarettes.
NPO for 8 to 9 hours for an upper GI. If they're also going to look at the small intestine, though, you suspend eating after the evening meal. So it could be like 12 hours, essentially.
The boot camp also had cigarettes.
The what?
They had cigarettes. That you cannot, you should
can't
not
have-
smoke.
correct,
Because
that-
we also get the.
Correct. No cigarettes or gum. Okay, you can have a single or double contrast study. Double contrast is going to have your barium and your gas-producing substance. Usually it's a powder, the crystals, or actually carbonated beverages can be used as well. Think I've ever seen them use a carbonated beverage? They give them Sprite to drink because it'll stimulate burping. Of course, you should not burp; it'll cause the little gas bubbles to form. All right, a biphasic examination equals combination, single, and double contrast during the same procedure, which they can do as well. They can start as a single contrast, then introduce the air later, thus turning it into a double contrast. That would be what we call a biphasic examination. Yes?
So they would give them the carbonated beverage as opposed to the crystals if they have like if they refuse the crystals or if they refuse the powder?
It could be if they just don't have them.
Oh, okay.
They won't be cheap. I'm sure a Sprite's a lot cheaper than those crystals.
Yeah.
Yes. Yeah, so for example, let's say I start as a single contrast. As the doctor's going, he's like, you know what? I want to go ahead and make it a double contrast. Introduce air, would introduce the crystals, it would then become double contrast. And because it started as single and became double, we call it biphasic. That means it started as single and became double.
But don't you, when during double contrast, isn't it like you're trying barium, you get barium?
It's not as optimal, but it's just saying if they introduce it later. Yeah. Yeah.
And that's because like they find something that they need to see, or
Usually they might see a pathology that comes up, or they suspect something like an ulcer or polyp, because you do get polyps in your stomach. I had them. Still gotta find my pictures to bring y'all. I had some stomach polyps. I got the pictures of them.
Is it because like they see something, they're like, oh wait, let's just add crystal or something?
Yeah, they suspect something.
did they
Typically.
remove them?
Hmm?
They remove them?
Mm-hmm.
Did it hurt like afterwards? Did they put you to sleep?
They did. I had 14 polyps removed.
Oh, wow.
Dang.
My last procedure. Huh?
Is there a reason?
It's genetic. Just genetic. Some people grow them more. And my family tends to, they call us polyp farmers. As long as you stay on top of it though, get them removed every few years, it's okay.
You can do them both.
How is it removed?
Like in
How's it removed? They just go in there and clip them out. Scope with it's a scope. So I had a colonoscopy with an endoscopy. So they put the scope in there and then they put like these little tweezers and just snip them all out.
But I thought polyps were in the colon,
They can be in the stomach too. They're most commonly in the colon, but they can also be in the stomach. All right, let's take a quick break, guys. Take y'all a quick little 10-minute break.